Thanks, Sushil. I'll try to stick to the time limit. We have been talking right from the morning and referring to drug-eluting balloons, basically doing their job and going away, not leaving a lot. So for the next 10 or 12 minutes, we'll try and focus on how they are supposed to do the job and what they are doing at the moment. So the story all started with balloons. We all know they come in all shapes and sizes and colors, literally. And stents, well, very nice, but perhaps we overdid it. There are so many downsides now that we need to be very careful as to which patient we are going to choose. This is another example where the patient can literally be transformed to an Iron Man, which really we don't want. So the whole situation is that how can we get the drug to the right place for the right job without causing too many other associated problems. And that is what Dr. Martin Leon also referred to repeatedly as one of the future thoughts which are going to make life easier, less complicated for our patients. So basically, all the drug-eluting balloons are looking at how to get the right drug at the right place only at the right place, not at other places. So basically, dissolution followed by coating disintegration and drug delivery. So the potential advantages obviously is they avoid leaving a permanent metal, avoid chronic inflammation, avoid the risk of a stent thrombosis, and even if there is a restenosis, it can be tackled as a fresh case rather than having 4 or 5 layers of metal right round before we think of retackling it. So basically, the philosophy is come, do your job, go away, leave nothing behind. So there are different technologies which have been devised to do this job. And the important point to remember is not all drug-eluting balloons are equal, because that is extremely important. If we try to say that all the technologies work the same way, perhaps we have something missing somewhere. So one of the technologies can be that you have a biological biofilm which is responsible for the drug elution in that short 30 or 40 second period and then retains the drug to do its work. And this is aided by having a hydrophilic spacer which allows more surface of the drug molecule to be exposed and absorbed to the vessel wall in question. So this is basically by the sequent please technology. Now the Dyer technology, initially there are 2 steps to it. The first one, the Dyer one, there was delivery just by simple diffusion. There wasn't any complicated technology. So you had a paclitaxel embedded in the balloon and there was a simple diffusion. Now this didn't work, obviously, because the Dyer 2 technology came up where they deployed a shellac in very small dosages as a fixing material for the drug. But still, there are a lot of variations, lot of problems here in terms of the drug delivery, which has to be very, very exact. There is another technology which is being deployed by a Medtronic balloon where the urea, although in very, very low dosages, very low concentrations, is being used. Now, if we go to the trials, only lately, better design trials have been done. Initially, it has been all observational analysis. So this is a long list of the trials done by the Dyer balloons. And a few of them I'll just give you a glance. These are debut trials, but it failed to show a significant benefit, even statistically. The Picoletto trial there was more mace in the drug-eluting balloon versus the drug-eluting stent. And the Spanish registry also, although it was done at many centers and had more than 225 patients and had a good safety profile, but there wasn't really much which came out of it. And so was the Valentine's trial. However, there is more robust data with the sequent please technology as of today. This is the first-in-man PACOCATH study, which was done in the in-stent restenosis and which showed a very robust difference between the two arms. But this was a small trial, just 30 patients. This is the series of the PEPCAD trials, PEPCAD 1 to PEPCAD 6, which is being tried out in different variations, be it bifurcation, be it in-stent restenosis, be it CTO, etc. Now, these are something else, PEPCAD DES study, which was released last year in the TCT, and they tested the paclitaxel coated balloon versus a plain balloon angioplasty for in-stent restenosis. And these are the two arms. Around 110 patients were randomized in ratio of 2:1. And there was certainly a difference in the late loss in favor of the paclitaxel coated balloon technology. PEPCAD 5 bifurcations, the main proponent hypothesis is that it will also, besides preventing the side branch restenosis, if you dilate the side branch and put a paclitaxel coated balloon there, it will also keep the main branch patent by achieving comparable result to a DAS without restenosis when combined with a BMS. So in the main branch, you put a BMS, do a drug coated balloon, and in the side branch, you do only a drug coated balloon. So this is the 30-day and 9-month follow-up, good safety and perhaps medium size effectiveness. Not very, very effective, but medium effective. Now this is a large registry of the sequent please, and this has more than 2,000 patients till some time back from all the Asia and European centers. And this is showing a very good, reasonable result. Considering that it is an all-comers registry, there is not really low-risk cases which are here. The main thing is that without diabetes, you have an extremely good result. Obviously, as expected with diabetes, those results can get to be slightly less better. But on the whole, you have good safety and an acceptable MACE and TLR TVR. What about AMI? Because that is the thing where everything has to prove itself to cross the final barrier. So drug-eluting balloon and AMI was tried out in 150 patients, and the conclusion was that drug-eluting balloon followed by bare metal stent failed to show angiographic superiority to bare metal stent. However, there were less incomplete appositions compared to drug-eluting stent. So, I mean, clinical superiority is still to be proved, but these are initial steps which have been taken. Another sort of large area where they can be applied effectively is small vessel disease. So, in this study, when the drug-eluting balloon were applied for small vessels, that is basically less than 2.25 millimeter in diameter, there was a slightly less late loss. Of course, their main area of application still remains in-stent restenosis, because that is where you don't want to put more, keep on putting more metal and try to tackle that without leaving anything extra there. For the Impact Falcon, these are the trials going on not only in the coronary but in the peripheral also, peripheral disease. The results are awaited, but yes, in the peripheral arteries, the results can be quite gratifying. As you can see here on the top panel on the right side, you have an uncoated balloon which has been followed up, and on the follow-up in the bottom right corner, you have a paclitaxel coated balloon vessel. Of course, all peripheral arteries will not respond like that, but even if a few do, I think the purpose is partly served. Now, just a few reminders for our young friends who are just starting the intervention or carrying along for the last 4 or 5 years. Please remember, drug-eluting balloon is not only a balloon. Please don't use it for primary dilatations. No. It is a system to deliver a drug to the right place in the right concentration and in the right time. So how to go about it? These 4 steps are extremely important. First is pre-dilate with an angioplasty balloon. If it is in-stent restenosis, you can't really place the balloon correctly, there is slippage, maybe use a cutting balloon. Step 2, try to dilate maybe progressively but obtain a stent-like result if possible. Step 3, choose the drug-eluting balloon slightly longer than the lesion. The peri-stent area or the peri-lesion area should also get the drug. And final step is inflate the drug-eluting balloon to the recommended pressure and the recommended time. Please, again, all drug-eluting balloons are not equal, and please follow the instructions whichever drug-eluting balloon you are using. So basically, if we try to summarize, the drug-eluting balloon is not stopping your vessel recoil. So if that's the problem, please put a stent. If after an initial balloon dilatation you see there's a lot of recoil, there is no point at all in using a drug-eluting balloon. But yes, for restenosis and sometimes very selected de novo lesions like small vessels, yes, you can use it. So basically, if you want to summarize, in-stent restenosis, bifurcation, small vessels and peripheral, perhaps below the knee where you have smaller vessels. These are the 3 or 4 areas where drug-eluting balloon will be quite useful. Now, these are some very short examples. You have this ostial LAD, very tight in-stent restenosis occurring at 6 months. So you give it a drug-eluting balloon and this is the final result. And this patient has crossed 4 months mark now and is doing very well clinically. So we hope he will be all right. Now this is a diagonal stent. This was a very large diagonal. Drug-eluting stent was put away from the ostium and still it re-stenosed. So, I mean, since this was a large diagonal, we used, you can see here, we are using a slightly longer drug-eluting balloon than the lesion itself. And this is the final result for the diagonal. And this patient is also crossed around 3 months. You can also use it in combination with the stents. But then, for example, this vessel, you have 2 lesions and then followed by a long segment of a small vessel. So here we are using a stent. Here again we are using a stent, but in the distal portion where it's perhaps just even 2 millimeters, we are using a long drug-eluting balloon. And this is the final result, not quite bad. Now this patient has done more than 9 months of follow-up and is doing very well. So where is this technology in 2010, 11, 12? Have we progressed? Well, we seem to be growing up, as is seen in this picture, but growing up slowly. Can they leave everyone behind? We don't know. More technological advancements have to come, more correct applications, more randomized trials. So from leaving nothing behind to leaving everyone behind, there is still a gap. In the European guidelines, we have a 2A recommendation with level of evidence B, where it says that drug-eluting balloons can be considered for treatment of in-stent restenosis after prior bare metal stent. The German guidelines are perhaps more aggressive, mainly because this technology originated from German researchers. And they say that even in single vessel disease, you can have a BMS spot stenting followed by a drug-eluting balloon, or you can use drug-eluting balloon in bifurcations. Of course, the very big advantage is for patients who cannot tolerate long dual antiplatelet therapy, or perhaps who are due for some surgery which may be imminent in the next 3 to 6 months. Because if you are only using a drug-eluting balloon, well, you can stop the dual antiplatelet therapy unless you have used it in combination with a stent. So these are some newer advantages, advances which will come over in the next 1 or 2 years. But please remember, all of you, please look at the literature very carefully. No two things are equal, and this cannot be more applicable than in the case of drug-eluting balloons. So please look very carefully for a deeper picture that where is this all technology build up leading us to. Thank you very much for a patient hearing.